You are muted, Dr. Meenu, please.
Greetings, everyone. Very good evening to all of you. It's a warm winter evening. We are all ready for an academic feast today on a topic of neck contracture, anesthesia management, and its challenges. I welcome our esteemed Honorable Secretary, Dr. Bajwa sir, for this unique PG online classes, which ISA has held on every Monday, 6:15 p.m. onwards. It's a great initiative, sir. Dr. Bajwa, sir.
Thank you, Dr. Meenu. Before I proceed something, I welcome Dr. J.V. Divatya sir, our President ISA National, and I think Dr. Bimeshwar sir, he also will be joining soon. So, Dr. Divatya sir, a word of wisdom from your side. Just wait, sir. Just wait, sir. I will make you a co-host. No, Divatya sir, you can unmute yourself.
Yeah. Yes. Good evening. Good evening. So again, thank you very much for this very excellent online activity that the ISA is doing. This is again a series of online classes for focused postgraduate students. And again, I thank Dr. Pratibha Jain Shah and Dr. Lalwani for taking charge of this particular meeting on a very important topic on a burns contracture. I won't hold you up any longer except to wish you all the best and thank you for helping the ISA in taking care of the academic needs of PGs and many others members of the society. So please go ahead. Thank you.
Thank you, sir. Dr. Bimeshwar, are you there? I think he may not be able to join at the moment. Anyway, Meenu, it's not a warm winter. Actually, these are very cold winters.
It's a cold winter, sir.
You told warm wishes on the
warm wishes, sir.
Warm wishes anyway. That is required.
It is warm winter in Mumbai, so I think she was absolutely right.
No, but she
yes,
is
sir.
she is in Haryana. Haryana, Punjab are the coldest regions of the country.
By seeing so much beautiful faces ready for academic learning, it's a warm winter, sir.
Yeah, fine. It's a warm. Let me agree with you only. It's a warm winter. So it's really a very good topic today about the post-burn contracture of the neck, and it's a very difficult, case because during our post-graduation times also, since so many years, we have seen that these always pose a different type of challenges. Not because every case is a different, the degree of the contracture is different, the degree of suppose a person is having a difficult airway, and on the text of that, you have got additional contracture of the neck also. So it's a hell lot of experience for that person. It's a very difficult, and you share the airway with your plastic surgeon, whosoever going to release the contracture and how to proceed. So many challenges are there. I think Anna boss is very, very, much confident today, made confident especially by Dr. Pratibha Madam and Dr. Jaya Lalwani to deal with such type of cases. So I wish my best wishes with Hana today. You go ahead with it and make proud your teachers proud that what they have taught to you during these days. Back to you.
So to start with this session, we invoke the blessings of Ma Saraswati. Hear it.
तब चरणों प्रणमामि।
In continuation of the event, I welcome Dr. Pratibha Jain ma'am for this session. I welcome my co-coordinator, Dr. Asha. She is a consultant in Hyderabad, for welcoming Dr. Pratibha.
I think I have to unmute her. Just wait, just wait. Asha, you can unmute yourself now.
Yes, sir. Good evening, my dear ISA members, and good evening, doctors. Good evening to everyone in the participating in the meeting today. I'm here and I'm glad to take this opportunity. Thank you for the opportunity. And it is my pleasure and it is a distinct honor to present to you a luminary in the field of anesthesiology and pain medicine, Professor Dr. Pratibha Jain Sharma, currently serving as a professor and head of the Department of Anesthesiology and Pain Medicine at JNM Medical College, Raipur. Dr. Shah ma'am brings an impressive wealth of experience and expertise to our summit. With an illustrious teaching career spanning 26 years, Shah ma'am has been an guiding force in shaping the future of anesthesiologists. She has made significant contributions to academia with 57 publications in national and international journals and the authorship of 7 chapters in books. Dr. Shah ma'am's commitment to advancing medical literature is further underscored by her role as the associate editor for the Indian Journal of Anesthesia Central Zone and the Journal of Neonatal and Critical Care Anesthesia. As a distinguished leader, Dr. Shah ma'am is the founder president of Raipur Society of Study of Pain and has served as the past president of the ISA Raipur branch from 2013 to 2016. Her organizational acumen is evident in her role as the organizing chairman of the first obstetric update under the AEGIS of Indian College of Anesthesiologists in December 2023, and the workshop on the perioperative neonatal resuscitation under AEGIS of NAS. Dr. Shah ma'am's exceptional contributions have not gone unnoticed. She has been honored with the National Proficiency Award by ISA in 2020 and Fellowship of Indian College of Anesthesiologists in 2021 and the Appreciation Award by the Honorable Health Minister Chandigarh in 2021. She has also received the Excellence Award by the Honorable Chief Minister of Chandigarh in 2019 and the second place at the Annual Medical Summit 2018 Chennai. Her dedication to the spreading public awareness has earned her accolades, including an award by the Academy of Traumatology in 2017. As a course faculty and instructor for BLS, ACLS, and FCCS courses, COLS and BCLS and CCLS, Dr. Shah ma'am has been instrumental in shaping the skills of medical professionals. Internationally, Dr. Shah ma'am has represented India at prestigious events such as the World Congress of Pain in 2018 Boston and World Congress of Pain in 2022 Toronto and NWAC 2013 in Bangkok. Dr. Shah ma'am's commitment to education extends to her role as a PhD guide in DDU and Ayush Health University. As an external examiner and thesis reviewer for various universities and NBE, she continues to contribute significantly to shaping the academic landscape. We are privileged to have Dr. Pratibha Jain Shah ma'am with us today, a true trailblazer in the field of anesthesiology and pain medicine.
Welcome, Dr. Jaya Lalwani ma'am. Dr. Asha, please have a brief of Dr. Jaya ma'am.
Yes. It is with a great pleasure that we introduce our distinguished speaker, Dr. Jaya Lalwani ma'am. Dr. Jaya Lalwani ma'am is a seasoned professional in the field of anesthesiology and pain medicine, currently serving as a professor in the Department of Anesthesiology and Pain Management at JNM Medical College, Raipur. Dr. Lalwani ma'am brings a wealth of expertise to our summit. Dr. Lalwani ma'am is not only a dedicated educator but also a dynamic member of the medical community, serving as a member secretary of the Institutional Ethics Committee. Her commitment to advancing medical education is further evident in her role as an instructor for BCLS, CCLS, FCCS, and FCCS OPS. In addition to her academic roles, Dr. Lalwani ma'am has made significant contributions as an executive member of executive member of the Society for the Study of Pain Raipur. Her organizational skills have been showcased as the organizing secretary of the 6th Central Zone and 11th CGISACon 2014 and state level workshops on ethics and medical research as well. Dr. Lalwani ma'am's dedication to excellence has earned her prestigious awards, including the Best National Trainer by the Ministry of Health and Family Welfare in 2014 and the Presidential Appreciation Award by IMA Raipur in 2015. A prolific researcher, Dr. Lalwani ma'am has authored numerous publications in 30 national and international journals and has delivered over 50 lectures in national and zonal and state conferences. Her areas of interest encompass obstetric anesthesia and spreading public awareness of CPR. Please join me in welcoming Dr. Jalan Waniman, whose wealth of experience and commitment to medical excellence promises to enrich our summit discussions. Thank you.
Thank you, Dr. Asha, for this. I handed over stage to Dr. Pratibha ma'am for introducing their students for next today's speaker of the topic.
Good evening, everyone. Good evening, Dr. Meenu. And I'm very thankful to ISA Headquarter National Branch for giving this opportunity, giving this platform to us. And we hope we will fulfill the desired, whatever we are required from us. So we have Dr. Anna Bose. She is final year student in my department. She is going to present on post-burn neck contracture release. So Anna, before starting your presentation, can you just summarize what are the things you will keep in mind while managing this case for PSC before you are doing PSC to this patient?
Yes, ma'am. Good evening, everyone. Some of the perioperative considerations while dealing with a case of burns and post-burn neck contracture is the age of the patient, the cause of burns, the extent and depth of burns, any associated inhalational injuries, and the presence of the contracture and associated difficult airway. The current regimen of fluid resuscitation that the patient is on, their NPO status, what enteral feeds they are on, and the type of surgery and the duration of surgery. These are some of the important considerations.
Okay. So while keeping all these things, please present your case.
Yes, ma'am.
Share your screen.
Just a minute for some rules and regulations. May I take your kind attention for that? I request everyone to keep videos off if it is not required during presentation, to keep a minimal of disturbances in between, and keep yourself muted. Whenever whosoever have some queries, please enter it in chat box. That will be addressed as and when basis in between or at the end of the session. Thank you.
Anna, please share your screen. Before that, I will congratulate the headquarter and especially the Bajwa sir for successfully conducting this PG classes since 2 years, almost 2 years are there. So thank you so much for conducting this and congratulations. So Anna, presentation.
So today I will be presenting a case presentation on a post-burn neck contracture case. This is a 25-year-old female who is a college student from Sarguja, Chhattisgarh, who was admitted in our hospital on the 18th of December. Her chief complaints was the development of a neck contracture following split skin grafting for thermal burns sustained 1 year ago, along with restriction of neck movement since the last 6 months. Patient was a victim of alleged assault 1 year ago when petrol was poured on her and she was set on fire in the streets. She sustained painful patches of burn injuries over the neck, upper part of the chest, both arms and dorsum of hands. There was no history of stridor, hoarseness of voice, cough with soot-stained sputum, cyanosis, headache, or altered mental status. The mother recalls mild breathing difficulty and facial puffiness between day 2 and 4. There was no history of any insertion of tubes or airway manipulation. She was on oxygen therapy via face mask, received fluids, antibiotics, analgesics, vitamin supplements, and underwent regular dressings in the hospital. She later continued these dressings at home, consumed a high protein calorie diet, but pain restricted physical therapy. The patient underwent contracture release in bilateral axilla and an excisional wound with split thickness skin grafting over the neck and chest 6 months after. Patient presently has band contractures extending from the neck up to the chest with restricted neck movements, which has developed over the 6 months since the split thickness skin grafting. There is no history of difficulty in speech, eating, or maintaining oral hygiene. No history of hospitalizations or surgery prior to the burn accident. There are no known addictions or allergies. She has a normal appetite and normal sleep cycle with regular bowel and bladder habits. No known comorbidities. She has an irregular menstrual cycle with hypomenorrhea, and her last menstrual period was in October. Coming to general examination, patient is alert, conscious, and cooperative. Her height is 5 feet and her weight is 42 kgs, and the calculated BMI was 18.2 kilogram per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema that was noted. Her heart rate was 62 beats per minute at the time of examination, with a blood pressure of 100 by 60 millimeters of mercury in the left arm in the sitting position. And her respiratory rate was 14 breaths per minute with an arterial saturation of 98% in room air. Coming to the airway examination, bilateral nasal patency was adequate and equal with a mouth opening of 2 fingers. On assessment, modified Malampati score was grade 3 and upper lip bite test was class 3. That is, she was unable to bite the upper lip. Thyromental distance could not be assessed and sternomental distance came up to 6 centimeter. Neck movement had restricted flexion and absolutely no extension and rotation. On local examination, we can see that the fibrous band-like scar spans from the anterior to the left lateral neck in the resting position from the mentum to the sternum. Patient is able to flex the neck and bring the neck and jaws to anatomical position while erect, but any attempts at extension away from the anatomical position results in significant pull at the lower lip. There is no tenderness on palpation over the scar tissue, and the sternal notch is palpable. Thyroid, cricoid, cricothyroid membrane, and trachea are not easily discernible on examination. There were no significant findings on systemic examination. To summarize, a 25-year-old female presented with a neck contracture following split thickness skin grafting for thermal burns sustained 1 year ago over the neck, upper part of chest, bilateral arms, and dorsum of hands with difficult airway and fixed flexion deformity, and she is planned to undergo a neck contracture release. Thank you.
I would like to share my screen. Thank you, Dr. Anna,
Yes.
for the summarizing the case. Thanks to ISA National Honorary Secretary, Dr. Supinder Bajwa sir, and a very good evening to all the candidates who have attended, joined this meeting. So Anna, you have summarized your case. We have already, keeping in mind the preoperative concerns in case of burns, I would like to know, how would you estimate the magnitude of burn injury in this patient?
The magnitude of burn injury can be determined by the extent of body surface area that is involved, along with the depth and degree of burns and the presence of inhalational injury. In order to estimate the extent of total body surface area in a burn injury, commonly in adults, we use the Wallace's rule of 9. In smaller burn surface areas which are discontinuous, the Palmer method is used. And for pediatric population, as the London Browder chart accounts for the age and body proportions, it is preferred in pediatric cases. Coming to the degree of burns, there are 4 degrees of burns based on the layer that is involved. So the first degree burns are involve only the superficial layer of the epidermis, and the first and second degree burns are considered very painful. Whereas the third and fourth degree burns, they are insensate as the nerve endings and nerve fibers are destroyed. And they usually heal by scarring. And most of the times, these are the patients who land up with neck contractures.
So what is the percentage of burns in your case?
In accordance with the Wallace's rule of 9, the upper part of chest accounts for 9%, bilateral arms accounts for 9%, and the neck and dorsum of hands approximately 1%. So the total body surface area burned is 20%.
So why are we concerned with calculating this area of burns? What is the importance of knowing the percentage of body burn in these patients?
Yes, ma'am. Ma'am, the percentage, it is important to know the percentage of body surface area that is burnt, because one helps us in identifying whether we're dealing with a case of major burns, and thereby helps us determine prognosis. In the acute scenario, it helps us to guide fluid resuscitation, and sometimes the areas involved may be typical sites for vascular access and monitoring, and that could be a challenge for us.
Here I would like to share a small piece of information about the London Browder chart. How it came into existence is very interesting. There was a Coconut Grove nightclub disaster in Boston, Massachusetts in 1942. It is the deadliest nightclub fire in the history till date. About 492 persons were burnt in that incident, and most of them were shifted for treatment to the Massachusetts General Hospital and the Boston City Hospital. Now, these fellows, Dr. Charles Lund and Dr. Newton Browder, they were working in the Boston City Hospital, and based on their experience of treating about these 400 people, they designed this chart, and which is used till date worldwide, the London Browder chart. So my next question.
Anna?
Yeah.
So Anna, you have mentioned that your patient didn't have any inhalational burn. How did you come to know that by history and examination that patient is not having inhalational burn?
Yes, ma'am. The possibility of an inhalational burn exists if a patient is found unconscious in an enclosed setting. Also, patients who sustain extensive cutaneous burns with the involvement of face with singed nasal hair strongly suggest the possibility of an inhalational injury. Along with that, there were no signs of any upper airway injury in the form of hoarseness, erythema or swelling of the oropharynx, and there were no signs of lower airway injury either in the form of stridor, dyspnea, or decreased oxygen saturation. There's also no history of prior ventilatory support. So since these features were absent, I ruled out the possibility of an inhalational burn injury.
Well said. And it is very, very important for us to know whether patient was having inhalational injury or not. But why this is important, Anna?
Yes, in inhalational burns. So in the early stages, if in acute stages, if the airway edema develops, then we need to be very alert, and repeated assessments are required, and it is better to secure the airway early than late. And also because of the inflammation, there's a lot of sloughed mucosal debris and inflammation and superimposed infections, which can cause bronchospasm, atelectasis, and pneumonia in these patients. Also, there are certain metabolic effects which also occur, as in the gas phase of the smoke may lead to carbon monoxide poisoning, and that leads to tissue level hypoxia, which can cause neurological symptoms. So appropriately starting oxygen, 100% oxygen, can reduce these neurological sequelae.
Right. So you have examined your patient, airway examination, right? So what are the airway related challenges in your patient?
Yes, ma'am. Ma'am, ASA defines a difficult airway where a conventionally trained anesthesiologist experiences difficulty in mask ventilation or tracheal intubation, or in both situations. And there are certain mnemonics that we have to remember these conditions which we may encounter. So in that, the first, in order to assess difficulty in laryngoscopy, we have the lemon mnemonic, in which L stands for look. Looking at what? The anatomical features which may pose a difficulty in mask ventilation and laryngoscopy. E stands for examination, and examination of 3-3-2. So in 3, we look at if the mouth opening is more than 3 fingers, higher mental distance of 3 fingers, or if the thyroid to floor of the mouth is around 2 fingers. M stands for the Malampatti grading, O stands for obstruction, and N stands for neck mobility.
How much is the mouth opening in your patient?
In my patient, the mouth opening is 2 fingers.
Okay. And what about thyromental distance?
Thyromental distance could not be assessed now.
Okay. So what are the challenges, airway challenges in your patient?
Yes, ma'am. The airway related changes that were found in my patient were a restricted mouth opening of 2 fingers, inability to protrude the mandible, a stiff submandibular space, grade 3 modified Malampatti, a short sternomental distance, a fixed flexion deformity with limited cervical flexion, and all of these suggest the possibility of a difficult laryngoscopy and intubation.
What about extension and rotation of the neck?
Ma'am, rotation of the neck was not possible, and even on extension, there was a pull on the lower lip.
Okay.
And the contracture bands made the identification of anatomical landmarks difficult, which is why external maneuvers like giving burp or cricoid pressure or even securing an emergency invasive access raises concerns.
Yes.
So you have examined the airway related changes in your patient. Now, there are certain physical findings from the examination of the patient or from the history which can be prognostic of difficulty with laryngoscopy or intubation. So can you enumerate the key points that you will note during the airway assessment of your patient?
Yes, ma'am. Before we start examining the patient, the first thing that we must do is have a directed patient history eliciting whether they've had any previous difficult intubation. And then we go on to assessing the mouth opening by observing the inter-incisor gap. We look at the size of the upper incisors and the presence for buck teeth. Modified Malampatti grading is observed. We look at the temporomandibular joint function in the form of the upper lip bite test, neck mobility, and presence of beard, short and thick neck or muscles. And the second part of our examination involves looking at anatomical measurements like the thyromental distance, sternomental distance, and neck circumference.
Yeah, change the slide.
How would you do the modified Malampatti examination of the patient?
Yes, ma'am. Before conducting a modified Malampatti examination, there are certain instructions that we must give to the patient. So the patient must be in seated position with the mouth wide open and the tongue protruded, but there should be no phonation and the observer should be at the level of the mouth.
Yeah. Can you, just for the audience, can you tell me what is Malampatti 0 classification?
Yes, ma'am. In Malampatti grade 0, the epiglottis is visible, like the epiglottis is easily visible on opening of the mouth.
So that shows that the laryngoscopy will be easy.
Easy.
Yeah, good. So the next question is, how will you perform the upper lip bite test? And what is the importance of
Yes.
doing so?
The upper lip bite test is to assess the temporomandibular joint architecture function and the architecture of the teeth. So in class 1, the patient is able to bite the upper lip above the level of the vermilion border. In class 2, the patient is able to bite the upper lip below the vermilion border. And in class 3, the patient is unable to bite the upper lip at all. And this suggests, and class 3 suggests that it will be it's correlated with a grade 3, grade 4 Cormack-Lehane score.
What about our patient?
In our patient, the upper lip bite test is class 3. So
Class
unable to bite the upper lip.
So that suggests?
That suggests that the temporomandibular joint is stiff and it is difficult to prognathe. The patient has difficulty in prognathe.
What is the clinical implication of that, Anna?
The mandibular mobility is restricted. This means
Yeah.
that yes. So this means that the space between the space for laryngoscopy is reduced and the larynx is anterior.
You'll have difficulty during the laryngoscopy. There won't be any alignment and movement at the TM joint is restricted. Now, how do you assess the thyromental and the sternomental measurements? You said now that these distances are important to assess the airway difficulty.
Yes, ma'am. Ma'am, for performing the thyromental or sternomental distance, we ask the patient to extend the head, but the mouth should be closed. And then we assess from the mentum to the superior thyroid notch, the distance between the mentum and the superior thyroid notch to assess the thyromental distance. And the sternomental distance is also performed in the same position. And but it is measured from the mentum to the sternal notch.
So in your patient, what is the sternomental distance?
The sternomental distance is 6 centimeters.
So clinical implication is?
That, ma'am, there will be difficulty in laryngoscopy and creating the oral pharyngeal laryngeal axis.
So there will be a difficult intubation. Correct.
So Anna, in your presentation, you have mentioned the burn contracture. That contracture is of grade 2 or 3. So what are the other grades and why it is important for us to grade the contracture?
Yes, ma'am. We follow the ONA's classification. The ONA's classification grades mentosternal and posterior contractures. In that, in grade 1, the patient is able to flex the neck and bring the neck and jaw to an anatomical erect position. And but the patient, when asked to look above at the ceiling, is unable to do so. In grade 2, as in my case, the patient is able to maintain an anatomical position, but any attempts at extension leads to a pull in the lower lip. In type 3, it's a fixed flexion deformity, and type 4 are posterior bands which prevent full neck flexion.
So your case is having severe anterior contracture. So why it is important? In what sense?
Yes, ma'am. Ma'am, in this burn contracture or fixed flexion deformity prevents us from from aligning the oral pharyngeal and laryngeal axis for direct laryngoscopy.
This one, yeah.
Yes, ma'am. Ma'am, further.
Second, chances of bleeding is also more, right?
Yes, ma'am. The more immature the band contracture, it has more tendencies of bleeding on excision.
Immaturity and maturity is different thing. Okay, classification, grading is separate. Okay? So type 3 is the outcome is also poor and the chances of bleeding and other things are more common.
So Anna, after assessing the airway and the type of contracture, you have concluded that it is going to be a difficult intubation.
Yes, ma'am.
With type 2 moderate anterior contracture. So
yes.
Suppose this patient is posted for contracture release under general anesthesia. What are the investigations you would like to order and tell us why they are important?
Yes, ma'am. Ma'am, this patient is posted for a contracture relief under general anesthesia. So I would like to order for a complete blood count, wherein I would like to rule out any possible anemia or infections that may be coexisting. I would like to also ask for a blood group and cross matching to arrange for blood because sometimes excision of these contractures can lead to bleeding. So accounting for that, I would like to ask for a blood group cross match. Then the sodium and potassium levels in the form of electrolyte should be asked because potassium has implications with the use of neuromuscular blockers. And along with that, I would like to order a urea and creatinine. And on imaging, I would like to see a chest X-ray to see the baseline situation of the lungs and also an ECG.
Why do you want to have electrolytes, sodium and potassium?
At this stage, ma'am, the potassium is important because it is known that depolarizing neuromuscular blockers like succinylcholine is known to have a dangerous hyperkalemic response due to the increase in extrajunctional acetylcholine receptors. And this could be detrimental to the form that it could even lead to cardiac arrest.
Yeah, rightly said. So it is very important to have a baseline serum potassium in these patients with burn injury.
Yes, ma'am.
So now how you have the investigations, whatever you wanted. And now how would you like to prepare the operation theater before taking this patient for the said surgery? That is a release of burn contracture.
OT preparations can avoid undue delays while performing procedures. So it is very important to prepare the OT prior. In that, the Yonker suction should be placed under the mattress on the right side head. Adequate, appropriate oxygenation devices and oxygen supply should be noted. The oral and nasal airways of the expected size and one size below should be kept with balloons checked. ETTs compatible with the video laryngoscope should be arranged and kept along with the stillet. Rescue devices in the form of a laryngeal mask, airway, and cricothyroidotomy set should also be ready. For positioning, a pillow should be kept for an intubation pillow should be arranged. Monitors should be set to continuous monitoring, and the anesthesia machine breathing circuits should be checked prior. Drugs for emergency resuscitation, sedation, analgesia, induction paralysis should all be kept in advance. And along with that, the entitled CO2, a bougie should be kept under the mattress, 2 laryngoscopes of Mach 3 and 4 with lights checked and video laryngoscopy plugged and turned on. And also along with this OT preparation, an important thing should be done, that is there should be prior intimation to the senior anesthesiologist and the surgeon to prepare for standby in case the need for an invasive airway access arises.
They should be there. Okay, senior anesthesiologist should be there, and you should give prior intubation to ENT personnel if in any case you are not able to manage the airway.
Yes,
So what are the special consideration for monitoring? Is it easy, or you need to have a special consideration monitoring of these patients?
Yes, ma'am. Ma'am, so sometimes the standard areas of where we apply the ECGs may be burnt or it may be slippery from the exudates and topical antibiotics. So in such a case, adherence of an ECG may be a problem, in which case we can either surgically fix the electrodes or we can apply it on dependent sites. Even pulse oximetry, sometimes if the hands are involved, then we can try other sites like the ear, nose, or tongue. Sometimes burn patients are, it's difficult to find a place to put a blood pressure cuff, and sometimes we may even have to put it over the burn surface. So in that case, we must ensure that sterility is maintained to avoid infections. And if extensive blood loss is anticipated, then an arterial line may be inserted. Temperature monitoring is also very important in these patients as they are prone to hypothermia. And even neuromuscular monitoring should be considered in these patients, as there is altered pharmacology with neuromuscular blockers in burn patients.
Okay. What about ETCO2? Though it's a basic standard monitoring as per the IS, this thing.
Yes, ma'am.
Concern. So that should be there. Okay. So why this temperature monitoring is important?
Ma'am, in burns patient, they are prone for hypothermia. This is because there are large exposed areas of skin which is there, and they have an increased metabolic rate. And this, added with the anesthesia related vasodilation and surgical preparations with alcohol, all of this can lead to increased heat loss from these surfaces. So they are at an increased risk of hypothermia, and hypothermia further increases the metabolic rate, and the oxygen demand overall increases in the patient.
Because of shivering, associated shivering. So what are the strategies you will do to keep your body temperature of these patients to normal? What is your target temperature?
Ma'am, the patient we must prevent hypothermia in the patient. So maintaining the temperature in the OT room between 28 to 32 degrees is standard. And along with that, we may use forced air warmer blankets. Thermal water mattresses are recommended, and fluid and blood warmers may be used. And we must try to minimize the skin surface exposure with the surface, and maybe wrap the head and extremities.
The parts which are not used, you should rub those and always give a warm fluid.
Yes, ma'am.
So, do you think vascular access is easy in this patient? Is there any challenge related to vascular access? And which size of cannula you will choose?
Yes, ma'am. Ma'am, in acute settings, especially hypovolemia leads to collapse of veins, and along with that, even resuscitation can lead to edema, which may obscure the visibility of existing veins. So, securing an access is difficult in these situations, and even sometimes the usual vascular sites may also be burned. So, in these cases, getting a peripheral access is difficult. And usually central venous catheters are inserted because these patients undergo large resuscitation volumes along with drugs, blood, and even need for parenteral nutrition. So,
which side you will choose in this patient for central patient?
In this particular patient, I can go for a subclavian venous catheterization.
I think that is involved in that is the site of burn. It's involved. So which side you will prefer?
Even a
burn is there over the chest, right?
Yes, ma'am. In that case, a femoral venous.
Yeah, you have to choose the femoral vein, right?
Yes.
And which bore size you will use? Which size of cannula?
For peripheral access, ma'am, an 18 gauge cannula.
As wide as possible, depending on the extent of the surgery and the volume fluid loss you are expecting. Okay. Jaya?
Yeah, so Anna, now you have established a good IV access. So OT is also prepared, the monitors are arranged. What are the options for airway management in this case? Can you outline your plan briefly?
Yes, ma'am. Ma'am, since this is a difficult airway, so it is important to have a plan prior to inducing the case. And so as a plan A, I would like to go ahead with an awake fiber optic nasotracheal intubation, followed by an awake video laryngoscopy if we are unable to secure an access with a fiber optic. Plan C will be release of a contracture under local anesthetic and ketamine, along with securing a supraglottic airway device. Plan D will be tumescent local anesthesia, and Plan E will be a front of neck access.
Okay. So why do you think awake fiber optic airway management is advantageous in your case?
Yes, ma'am. Ma'am, in this case, we are anticipating a difficulty with mass ventilation and intubation. So the safest approach would be to secure the airway in an awake state before induction of general anesthesia. And the advantage of doing this is that there is preservation of the airway patency. There's maintenance of spontaneous ventilation, and the patient is also safeguarded against the risk of aspiration.
Yeah. And the patient will also be able to obey your commands in case you are having any difficulty, like forward placement of the base of the tongue. If you ask him to protrude the tongue, he will obey your commands.
Yes, ma'am.
What are the contraindications when you will not go for awake fiber optic intubation?
The absolute contraindication is if the patient refuses, but even with proper counseling, we may be able to convince the patient that that is the better option for them. Some of the relative contraindications are hypoxia, progressive airway compromise, local anesthesia allergy, and in case of an uncooperative patient like in the pediatric population.
Okay. So how will you prepare the patient for awake fiber optic intubation? You are going with your plan A.
Yes,
The
ma'am.
patient is difficult to intubation with a fixed flexion deformity of the neck. So what are the steps to prepare the patient for awake airway management?
Yes, ma'am. Ma'am, there is a mnemonic with which I would like to enumerate the steps to prepare a patient for awake airway management, where A stands for adequate psychological preparation, D stands for decongestion of the nose, the next D stands for drying of secretions, T stands for topicalization of airway, S stands for sedation, and P stands for perioxygenation and performing the procedure.
Okay. So what do you mean by this psychological preparation? What you do?
Yes, ma'am. Ma'am, by explaining the procedure, which is vital in this case, we can develop a good rapport which increases the confidence and cooperation of the patient for this procedure. And also, as such, awake fiber optic is not a risky procedure. But in case of a failed intubation or cannot intubate, cannot oxygenate situation, or the need for a front of neck front of neck access, these possibilities need to be discussed and explained prior to the patient. And we must take consent in written documentation in the language that they understand, and it should be signed by both the patient and his guardian.
Absolutely right. So how do you decongest nose? Do you decongest both the nostril? A single nostril? And how do you perform?
Yes, ma'am. Ma'am, ideally both nostrils should be prepared, but before that we must check the patency. We must check the patency of the nostrils.
How do you
And
check?
yes, ma'am. One is we can perform a cold spatula test where we compare the area of mist which is forming over the cold spatula, and that can tell us which nostril is more patent. And secondly, by simply using a wisp of cotton and observing the movement in front of each nostril, we can determine which nostril is more patent than the
By
other.
blocking the other one, right?
Yes, ma'am.
Okay. How do you dry the secretion?
Ma'am, for in anti-syllagogues, so the importance of giving anti-syllagogues is that typically it should be given 15 minutes prior because it dries up.
Which route?
Yes, ma'am.
And which anti-syllagogue?
Ma'am, most commonly glycopyrrolate is used, IV 0.2 to 0.4 mg, and the other options are atropine and hyoscine. But glycopyrrolate is preferred because there is less vagolytic effect and it does not cross the blood-brain barrier. So the advantage of giving glycopyrrolate is that it dries up the secretion, and therefore when we perform topicalization of the airway, it doesn't dilute it, and also it improves the vision during fiber optic.
So suppose you have hyoscine and glycopyrrolate both. Which drug you will prefer?
Hyoscine has the advantage of both drying the airways along with a sedative effect. But nowadays, glycopyrrolate is available and more preferred.
Because of the availability, we prefer glycopyrrolate. Otherwise, if iocine is available, we can go for that, right?
Yes, ma'am.
Okay.
What are the areas to be topicalized for a successful fiber optic intubation?
There are three anatomic areas that we should focus on: the nasal cavity and the nasopharynx, the oropharynx, and the hypopharynx, larynx, and trachea.
Which local anesthetic is most commonly used for topicalization of the airway? There are a wide array of local anesthetics available.
Yes, ma'am. Ma'am, lidocaine is most preferred as it has a rapid onset and it has a high therapeutic index, and it is available in a wide variety of preparations and concentrations.
What is the maximum dose of lidocaine you can use for topicalization of the airways?
As per DAS guidelines, ma'am, 9 milligram per kg can be used.
This should be noted because previously it was 4 to 6, they said, but the recent guidelines, they suggest up to 9 milligrams can be safely used for topicalization. So how will you achieve this topicalization of airways?
Yes,
Because
ma'am.
this is awake intubation. So unless that it is properly anesthetized, the patient won't allow you to do the procedure.
Yes, ma'am. So first we will position the patient in a semi-recumbent position, and based on whichever is the more patent nasal passage, we will apply oxymetazoline drops, and followed by nebulization with 2 ml of 4% lignocaine. And then we apply soaked cotton buds, either using pofenylkane, which is recommended in DAS guidelines, or with the more available 5 ml of lignocaine 2% and 1 in 2000 concentration of adrenaline. And then these cotton buds are inserted in the nasal cavity and kept for about 3 minutes. Next, we apply 4 puffs of 10% lignocaine, and this delivers around 10 milligrams. And so two puffs should be given on each side in the tonsillar pillars and the posterior part of the throat. Then we go on to giving 4 puffs of 10% lignocaine in the nose and postnasal space. Once we are done with this preparation, then we subtract this from the maximum dose, and then we leave the remaining amount of 4% lignocaine to be used as a part of the spray as you go technique while doing the endoscopy. And for a more directed strain, we can use an epidural catheter also.
So the weight of your patient was?
The weight of my patient was 40 kgs.
How much is the total permissible dose of xylocaine and how much have you injected by different methods?
Ma'am, assuming that the permissible limit is 9 mg per kg, and this is a 40 kg individual, so around 360 milligrams can be given.
So you are in the safe range up till now.
Yes, ma'am.
And still we have some margin while for spray as you go technique. Because while you are advancing the tube, you may need to spray the lignocaine if the patient demands.
Okay. So suppose here you have used safer dose, but how do you detect local anesthesia toxicity, Anna, if suppose it occurs? What are the signs and symptoms?
Yes, ma'am. Since we are using such so many concentrations and varieties of lignocaine, it is sometimes possible to land up with lignocaine toxicity, and we should ask the patient if they are experiencing any perioral tingling sensation with a metallic taste, or whether there is a tinnitus, or they are feeling dizzy or unwell. These are some of the early signs of lidocaine toxicity.
Okay. And how do you manage suppose it occurs?
Ma'am, if it occurs, we must, the intralipid emulsion is the drug of choice.
It should be there in OT in your preparation because you're topicalizing, you're using local anesthetic agent. So that should be there in your OT. So are you aware about any block and whether they are feasible in your case to anesthetize the airway?
Yes, ma'am. To supplement topical anesthetics, there are certain nerve blocks which are present, like the glossopharyngeal nerve block, which may be performed at the base of the tonsils, or the superior laryngeal block at the level of the thyrohyoid membrane, the transtracheal block to anesthetize the subglottic region, that is the larynx and trachea. These are some of the blocks that may be used. But in our case, it is not possible as the landmarks are not discernible properly.
Yeah, so we'll have to rely on the topicalization of the airway, which you achieve by the different methods and rightly described, Anna.
Yes, ma'am.
So now the topicalization is done, and the Difficult Airway Society awake tracheal intubation guidelines, they highlight the key components for awake tracheal intubation by this mnemonic. That is the stop. So S is small. Can you tell me why? What is the role of sedation?
Yes, ma'am.
Why S is small in this mnemonic?
Yes, ma'am. So this mnemonic tells us the key components before performing an awake tracheal intubation, and S stands for sedation, T stands for topicalization, O is for oxygenation, and P is for performing. But S is in small case here because it is optional, and also they are recommending minimal sedation to achieve maximum cooperation by the patient.
Minimal, you said this minimal sedation. Can you elaborate what is minimal sedation?
Yes, ma'am. Minimal sedation is a state in which the patient responds normally to the verbal commands while maintaining patent airway, spontaneous ventilation, and cardiovascular system is not affected.
So how will you achieve this sedation? Though minimal, but you have to use some agents to achieve the sedation.
Yes,
what are the commonly used sedative agents for awake airway management?
yes, ma'am. Ma'am, first of all, before choosing any sedation agents, we must note that it should be given in tighter doses. We must avoid polypharmacy and restrict ourselves to one to at max two different agents. And it is better to use agents which have a reversal agent. So, keeping those points in mind, DAS recommends the use of remifentanil in an infusion of 0.5 to 1.5 micrograms per kg per minute. And bolus doses are usually avoided because they can land up with muscular rigidity or chest wall rigidity and respiratory depression. And if at all remifentanil has to be joined with any other drug, then midazolam is usually preferred. That is also because both of these have reversal agents, opioids, naloxone, and for benzodiazepines, there's flumazepine. So these are usually used, and even dexmedetomidine is a drug which is seen to have good patient acceptability. So it's usually given in a bolus of 1 microgram per kg, followed by an infusion between 0.2 to 0.7 microgram per kg per minute.
So the dictum is with the sedative agents, you have to go low and go slow. You have to give minimal dose and then you can escalate if needed. Dexmedetomidine is increasingly being used these days. What are the side effects that can occur with its use, Anna?
Ma'am, with dexmedetomidine, commonly patients may land up with bradycardia, excessive sedation, and even hypotension.
Sometimes there may even be hypertension. How will you manage these complications? If there is hypertension, what to do?
We must immediately stop the drug. That is one thing. If the patient lands up in hypotension, then phenylephrine is the drug of choice. And if the patient has bradycardia, then we must have atropine at hand.
Yes, you're right.
Your fourth component is pre-oxygenation. What are the different techniques of oxygenating these patients? Because this is very, very important. While doing awake intubation, you have to pre-oxygenate so that you will maintain oxygenation and ventilation, spontaneous ventilation, right?
Yes, ma'am.
What are the different techniques of oxygenation?
Ma'am, we may use nasal cannula to supply oxygenation while performing this case. And now DAS recommends the use of high flow nasal oxygen between 30 liters to 70 liters per minute for good pre-oxygenation and to reduce apneic time. There is also the technique of transnasal humidified rapid insufflation ventilatory exchange, which also is providing high flow rates of oxygen. So it drives off.
How much flow?
Yes, ma'am.
How much flow you'll give and try?
Ma'am, 30 to 70 liters per minute.
Okay.
And it drives off the dead space gases, and it increases the oxygen levels and gives us more apneic time to perform the procedure.
Okay. So you
This
have
pre-oxygenation is replaced by the term peri-oxygenation. Right,
Yeah.
you have to continuously supplement oxygen before intubation, during intubation, and after that till you induce the patient.
Yes, ma'am.
So you have done everything. You have prepared your patient for awake fiber optic. So now, how do you perform fiber optic?
Yes, ma'am. Before performing a fiber optic, ma'am, we must ensure that the light source and video monitors are in proper working condition. And we must check the white balance, see if the images are being focused or not, lubricate the end of the insertion cord, apply anti-fogging solution prior, and also connect the suction and oxygen to the suction port for good visualization when we perform a fiber scope. And even the the endotracheal tube should be placed prior in a warm bath so that the tip is softer. So before performing the fiber optic, the patient, as in the primary operator, the person who is going to perform the fiber scope should have direct line of sight with the patient, video monitors and the patient monitor, and the anesthetic assistant should be right next to the operator and with easy access to the airway trolley. So the endotracheal tube is preloaded onto the fiber scope, and it is advanced through the more patent nostril through the inferior meatus, and then it is steered into uh, along the posterior pharyngeal wall and with the sago technique. And the tracheal rings, once identified, we advance the scope until it reaches the carina. And with the help of an assistant, the tracheal tube is then dislodged from the scope, and under vision, we intubate the patient.
What are the different positions of the patient in which you can perform your fiber optics? And what should be your position in respect to patient?
Ma'am, the patient can be in semi-recumbent position or in lying down position. And in the semi-recumbent patient, we will be facing the patient. And while performing in a lying down position, we must be behind at the patient head end.
Right. So main purpose is that video monitor should be in front of the person who is performing, and the monitor, everything is in your axis.
Yes.
Okay. Okay.
What are the common reasons for failure while performing the fiber optic guided intubation?
Yes, ma'am. Some of the problems can arise because of inadequate drying and decongestion and airway topicalization. So in that we commonly encounter, if we rushed in a rushed preparation state, these problems might arise and we may not get the patient's cooperation. Also, while navigating or advancing the fiber scope, the tongue might obstruct the fiber scope. So in that case, we can ask the patient to protrude the tongue. That will allow, or we can, if possible, which is not possible in our case, but a chin lift may be given in order to move the tongue from the field of vision. And then hang-ups may occur due to incorrect equipment diameter, as in the fiber scope and the ET tube diameter. And there can be associated fogging of the scope, and airway bleedings may occur if the expertise of the provider is not adequate.
So how will you overcome the fogging of the flexible scope?
The fogging of the scope, ma'am, commonly we attach the suction port or the oxygen delivery port to avoid the fogging of the vision.
Yeah, and again, you have to take care of the bleeding. So proper decongestion of the nasal cavity, you said, is very important, because once it starts bleeding, then it is very difficult to negotiate with the fiber scope.
Yes, ma'am.
What are the hang-ups and what are the ways to tackle these hang-ups?
Ma'am, hang-ups occur due to the difference in size between the fiber scope and ETT, as in it leaves a cleft, and this leads to, and so when we try to intubate the patient, it sort of impinges on the surrounding laryngeal structures. So, in order to overcome that, when we are performing a nasotracheal intubation, the ET tube can be rotated clockwise so that the bevel goes anteriorly, and this prevents the endotracheal tube from impinging onto the epiglottis, and we are able to insert the tube. And one of the other techniques is if we have the availability of a Parker flex tip, which is said to be a more blunt and softer tip, then it is seen that with fiber optic there is a high first pass success rate.
Yeah, but these tubes are not easily available at all places. This was about the nasotracheal route you followed. But while we are doing orotracheal, which most of people are experienced with the orotracheal route, sometimes the resistance is met as the endotracheal tube reaches the glottic inlet. So how to overcome this resistance and let your tube follow the right track?
Yes, ma'am. Ma'am, one of the issues while negotiating a tube through the oropharyngeal axis is that one is that the fiber scope tends to dislodge off the midline. And in such a case, oral airways, there are special oral airways which are there to guide the fiber scope. And these, mainly there is the Ovosapien, the Berman, and the William oral airways. And this fiber scope, once we are trying to intubate the patient, then we may rotate the tube 90-degree anti-clockwise in order to negotiate the tube through the vocal cords.
Yeah, sometimes it impinges on the right arytenoid. So first you withdraw the endotracheal tube. You have to do a side withdrawal of the endotracheal tube, and then you rotate in the counterclockwise 90 degrees.
Yes.
If the flexible bronchoscope gets stuck inside the endotracheal tube, how to manage? You will not be able to withdraw after you have successfully passed the tube. You have railroaded it through the fiber scope, and now you want to withdraw the flexible scope, right? But it gets stuck inside the endotracheal tube, and you're not able to do it. How will you manage?
Ma'am, commonly the fiber optic may get stuck through the Murphy's eye. I mean, it may get stuck while we're trying to take it out. It may go and like get dislodged in the Murphy's eye. In that case, we shouldn't try to forcefully take the fiber scope out because it's a very delicate instrument. So in that case, we will have to take both the fiber optic as well as the ET tube out in a single minute and procedure.
You have to remove them together.
Yes,
and
ma'am.
what precautions will you take to prevent the accidental scope withdrawal before intubation?
Yes, ma'am. If we sometime once we intubate the patient, we must take the fiber scope. We must withdraw the fiber optic while visualizing the tracheal rings. Because if we blindly take it out, there's no guarantee that the fiber scope and has dislodged into the oropharynx and we have placed the ET tube elsewhere. So it is important to visualize the carina, the trachea, while we are taking the fiber scope out.
Yeah, because at the time of railroading, you are not able to see where you are advancing the tube. Prior to advancing, you can visualize where are you. At the time of advancing, it is not possible to visualize.
Yes, ma'am.
So, Anna, you have made everything for this, for intubating this thing, intubating with your fiber optic. But suppose the plan A fails, then what is your next plan?
Ma'am, as a part of plan B, since the airways are already prepared, and I have access to a video laryngoscope. So I would like to go ahead with a Navig video laryngoscope, because even with video laryngoscopes, there is even if there is no alignment of the oropharyngeal laryngeal airways, we are still able to perform, and there's also less distortion of images with secretions and blood. So we can use a video laryngoscope.
But for video laryngoscope, you should have an adequate mouth opening, right? So if the mouth opening is less than 2 fingers, what will you do? How do you manage the airway?
Ma'am, so there are video laryngoscopes which may be inserted even with a mouth opening of 2 fingers, and namely these are the McGrath Series 5 blade and the AirTrack optical laryngoscopes. But these may not be readily available in most of the places. So in that case, we can consider releasing the contracture in the neck under local anesthesia and ketamine. And then because we can insert a second generation LMA, and since we need a definitive airway here, so we can intubate through the second generation LMA.
So after contracture release under ketamine, you can put according to the need of the this thing, whether you want a definitive airway or not. So if definitive airway is required, then either you have to plan for direct laryngoscopy and intubate with buzi. But if it is not possible, you can put a supraglottic airway device, second generation, and through that you can intubate. Okay. And if definitive airway is not required, then you can go for laryngeal tube if it is available in your setup.
If the mouth opening is very less than 2 fingers, which of the supraglottic airway devices can be used? There was one question in the chat box that in peripheral centers, when these advanced airway gadgets are not available, what can be done?
Yes, ma'am. Ma'am, if the mouth opening is less than 2 fingers and it is not, we don't need a definitive airway, then there is the combi tube and the LTS tube which can be used to secure the airway. But in case a definitive airway is required with the mouth opening which is less than 2 fingers, then probably it is better to send to a center where fiber optic is available, or if appropriate and we have competent people, then the front of neck access should be considered.
Front of neck access is also not very easy with this large fibrous band in front. So better is to release the contracture under ketamine with local anesthesia and then go with supraglottic airway device. Combi tube also is a good option because whatever place it follows, you can secure the airway and get the contracture released.
Yes, ma'am.
How much ketamine you will give for contracture release?
Ma'am, ketamine may be given 1 to 2 mg per kg.
No, you have to use a laser doses, 0.5 milligram per kg, along with
Glycopyrrolate and midazolam as pre-medication.
Anna, I think you are muted. I can't hear you.
Now she's audible.
Okay.
Anna?
Yes,
Now,
ma'am.
along with
Yeah,
ketamine,
she's
what
audible.
we give?
Yes, ma'am. Ketamine should be given along with glycopyrrolate and midazolam
Okay.
to
And
reduce.
then you
as-
have to give local anesthetic agent.
Yes, ma'am.
So one of the plans you said is you will be using tumescent anesthesia. It is but no longer used now. Can you tell me something about it?
Yes, ma'am. Tumescent local anesthesia is no longer popularly used because if we look at the preparation of the tumescent mixture, it has 30 ml of 2% lidocaine, 1 milligram of epinephrine, 1 ml of hyaluronidase, and 450 ml of vinolactate. So it's a very large volume of diluted lignocaine and adrenaline mixture, which is subcutaneously infiltrated into the contracture, so that it sort of swells the contracture up into a form tumescent form, and it is easy to excise. But the problem is that there is chances of water intoxication, local anesthesia toxicity, and also the risk of embolism, air embolism is present. So that is why it is no longer popularly used.
Yes, tumescent means swollen. With large volume, this much large volume, we are injecting the scar and the subcutaneous tissues. It gets infiltrated and it causes it to swell, and then the surgeons release the scar.
Basically, it's a hydrodissection, right?
Yeah.
So suppose you have already mentioned, I think, if all attempts at securing an airway fails, then what is your next approach? So it depends on whether that surgery is really needed. Then if it is really needed and you'll end up in cannot intubate and cannot oxygenate situation, then in that case, you have to go for front access. But if you can, if surgery is not emergent, then try to awaken the patient and shift that patient to a higher center where all the facilities for intubation is available. You have already discussed this thing, okay? So once your airway is secured, then almost your half job is done. So after that, when and which induction agent would you give for general anesthesia for inducing that patient?
Ma'am, since this patient is hemodynamically stable, so we can give propofol in this patient as the induction agent. And
but when will you give? When will you give induction agent?
After the airway is secured and we have confirmed it using a capnography, and there's visual confirmation that we have successfully intubated the tube. Then after that, once we are sure that the airway is secure, we can go ahead and induce the patient.
Right.
Yes, you have to make a double check for the tube position, and then only you give the anesthetic agent.
Then you have given induction agent. Now, which neuromuscular blockers you will prefer in this case?
In this patient, the tube is already secured. And so we would like to maintain muscle relaxant. We would like to achieve muscle relaxation. So for that, I would prefer using a non-depolarizing muscle relaxant. Atracurium can be given.
Okay. So is there any concern related to non-depolarizer in one patient?
Yes, ma'am. Non-depolarizing muscle relaxants are safe, but there is also a resistance which develops to the non-depolarizing muscle relaxants. And this happens due to the increase in the number of extrajunctional acetylcholine receptors. And along with that, it is further exaggerated in patients who are immobilized or have poor nourishment. So in these cases, the resistance is higher. There's also increased binding of the acid 1 alpha glycoprotein. And so the amount of free fraction available for acting is less. So overall, we need a higher dose and a more frequent dosing to achieve paralysis. And definitely neuromuscular monitoring should be present.
Yeah, if it is available, it can be used. It should be used.
Yes.
Now, what about fluids? What fluid you will give? Is fluid resuscitation important in acute burns?
Yes, ma'am. Fluid. Estimation of the total body surface area of burns and timely adequate resuscitation is key to the outcome of the patient. So if there is delayed or inadequate resuscitation, it leads to hypovolemia, tissue hypoperfusion, and overall hypovolemic shock with multi-organ failure. But again, aggressive over-resuscitation can lead to pulmonary edema, compartment syndromes, and even cerebral edema. So it is important to be able to estimate and adequately give fluids.
So how do you estimate the fluid requirement in a patient of acute burns?
The formula most widely used is the Parkland formula. And in that, 4 ml per kg body percentage is calculated. For the total fluid requirement is calculated. And half of it is given in the first 8 hours and the remaining is given in the next 16 hours. In patients who have
Which fluid does this formula recommend? The Parkland formula.
sorry, ma'am.
This fluid or colloid, what is the recommendation of fluid? Which fluid does this formula recommend?
This formula recommends it with ringer lactate solution.
Yeah, it is most commonly available and so cheap also, and a balance. It is balanced salt solution.
Yes, ma'am.
What
And
about colloids? What about the use of colloids?
ma'am, previously colloids were recommended later in the resuscitation because it was said that the capillary integrity was not restored, so it was injurious to give colloids. But now, to avoid or limit fluid creep over resuscitation, it is recommended to give colloid rescue as early as 12 to 24 hours after a burn injury.
Yeah. How much albumin to be given?
5% albumin is recommended.
Yeah, after the first day.
Yes, ma'am.
So how will you know that the fluids you are giving is helping you out? What are the end goals of fluid resuscitation?
Yes, ma'am. In order to know that we are adequately giving fluids to the patient, we use the general traditional blood pressure monitoring as well with a map of more than 60, and the urine output in adults should be more than 0.5 ml per kg per hour. And we also use the ABG to guide us into understanding if the tissue perfusion is adequate or not. In that, we look at the blood lactate levels, which should be less than 2, and base deficit should be less than -5.
Okay. So, Anna, do you know this term fluid creep? What is this?
Yes, ma'am. Ma'am, fluid creep generally occurs due to over-resuscitation, and especially if the total fluid requirements exceed more than 6 ml per kg total body surface area in a matter of 24 hours. And why this is dangerous is because it leads to the risk of developing compartment syndrome. And there are certain factors which leads to fluid creep, and especially this is if we tend to overestimate the burn size, or we have a hesitancy to reduce the fluid administration in patients with adequate tissue perfusion.
So, how you can avoid this?
Yes, ma'am. So, ma'am, it is now, as I said earlier, administering colloids as early as 12 to 24 hours is recommended because colloids increase the colloid oncotic pressure, and so it pulls the fluid into the intravascular space instead of allowing it to extravasate into the surrounding tissues. Hypertonic saline is also recommended as it limits the fluid volume that we are giving, but always there's a caution against hypernatremia. So sodium levels should be assessed regularly. And it also recommends high dose of ascorbic acid, which is said to reduce the reactive oxygen species, which are detrimental to the patient outcome. And along with that, it is very important to monitor if the patient is developing an abdominal, ocular, or facial compartment syndrome. It is important to measure the oxygen tissue perfusion with using the ABGs and assessing the fluid responsiveness.
Okay. So we are going back. So succinyl, what are the period when the succinylcholine is safe? After burn.
Yes, ma'am. Ma'am, so succinylcholine should be avoided after 24 to 48 hours and almost up to 2 years. It is because there is an increase in extrajunctional receptors. So during depolarization with succinylcholine, there is increased amount of potassium release, and this hyperkalemia can be detrimental. And this effect has been seen up to almost 2 years. So that is why succinylcholine.
How much potassium is raised with succinylcholine in normal patient and in burn patient?
Sorry, ma'am.
How much succinylcholine, how much potassium is raised with succinylcholine in normal patient and in burn patient? Is there any figure?
0.5 milliequivalents.
So one in normal patient, normal person, and in burn?
In burn, it can be almost up to
0.7 to 1.4 milliequivalent per. Even up to some of the report shows it will raise up above this 13. So that is dangerous. That may lead to cardiac arrest. Okay.
So after successful conduction of the case, what will be your extubation strategy? Remember, whenever there is difficult intubation, you have to be very careful with the extubation also.
Yes, ma'am. So a difficult intubation, as you said, is usually the possibility of an extubation failure is almost equal. And so the preparedness should be as much as during the time of intubation. So first of all, we must evaluate the patient readiness for extubation if they are cardiovascularly, neuromuscularly awake and fit. Then we must have the presence of skilled individuals to assist us with the extubation. We must have all possible things for reintubation, and even an tracheostomy set must be ready, and we must inform the ENT surgeon prior. Also, there should be availability of supplemental oxygen throughout the extubation process. And in this case, I would like to perform an awake extubation with the help of an airway exchange catheter, and then definitely observe the patient strictly in the high dependency unit in case the need for reintubation arises.
Yeah. So what this difficult airway society guidelines they suggest, it has to be a safe transfer. You have to see that there is proper oxygenation in the post-operative period, proper analgesia, and a staff to monitor the patient.
And irrespective of this thing, whether you are extubating awake or deep, main goal is patient should be calm. Patient should not fight, right? So that there won't be any dislodgement or problem with graft. So we have successfully conducted this case. We have discussed how we can perform release of post-burn contracture. But as anesthesiologists are versatile individual, what are the other role of anesthesiologists in burn patients? What are the situation where you will get the call, especially in burn patient?
Yes, ma'am. Ma'am, especially in acute burns patient, airway edema can and other factors may make the intubation difficult. And in that case, we may get a call to help secure the airway before the patient airway is compromised. Some of the other places, sometimes vascular access can be challenging, and for insertion of peripheral lines or central lines, we may get a call. Then even as a part of pain services, we we may be called.
Okay. So basically the burn patient, there are three phases, right? First is resuscitative phase, second one is stabilization, and third one is reconstructive phase. So in resuscitative phase, you will get call for resuscitation, for management airway, for fluid management, for putting an IV line, and during a stabilizing phase for dressing and other thing, and pain management also, and reconstructive for contracture release and that grafting and other thing. So this you have to keep in mind.
Yes, ma'am.
So we are done with this case presentation. Any query, any question? We are ready to answer. Thank you so much.
Thank you, ma'am.
Very well presented, Anna.
Thank
Yeah,
you,
but you have successfully intubated and extubated also and shifted to the HDU or ICU for recovery.
What is the one question is there in chat box? What is the best? Most of them we have already answered. What is the post management to cope with increase in blood pressure during extubation, especially in hypertensive patients?
So the routine protocol which we always follow for extubation, opioids, IV lignocaine, they can be given to reduce the stress response of laryngoscopy. No special issues with the burn patient.
basically the post-operative this thing, the rise in blood pressure is mainly because of pain. So we have to take care of that pain properly. And if it is still persist with proper pain management, then we can go for antihypertensive therapy. So and anxiolysis. So these are the two things which is most commonly lead to hypertension. So Dr. Madhur,
Over to you, moderators. Asha,
अरे मैं पूछ सकता हूँ क्या?
sir, please.
Anna,
Yes, sir.
suppose you are a final year student. I am a final year PG student on night duty, and suddenly what happens? A patient comes to me in the emergency, and I have to give the anesthesia with a burn contracture neck, landing up for emergency laparotomy or a cesarean section. How to proceed?
Sir, in this situation, the first thing I must do is inform the senior anesthesiologist.
Senior is not available. There is a fog, there is a rain, everything. You have to do it yourself. Senior will come into play later on. Now tell me about how you proceed.
Yes, sir. So in that case, assuming it's an emergency, the first thing I would like to do is, under ketamine, I would like to ask the surgeon to release the contracture. And after releasing the contracture, then depending on whether definitive airway is required or not, I will go ahead with the LMA insertion or direct laryngoscopy and intubation.
See, now I'm coming to that. When you start this type of preparation, you always have to alert the maximum manpower available in your hospital. The surgeon is not always, in the night. You can't just call him and come and prepare. Even the surgical access, the surgical procedure has to be prepared properly by the surgeon, attending surgeon. He has to plan. He has to be having all the equipment and gadgets and his workforce with him. And suppose it's for a section, I think it's well and good if we can achieve the subarachnoid block, but sometime if it fails, you have to go for the GA with the fetal distress. Then at that time, at least the first call should go to because these patients land up in obstetric emergencies ward. And you have to call the surgeon and there you have to plan it. The obstetrician may not be able to, get the uh, precision how to proceed. They will be just focusing at the uterus and the baby. It's up to you. You have to plan the things. You have to make up like the well-oiled manager who knows how to proceed, when to proceed, what type of equipment should be available with you in the operation theater. Now you have to garner all those support, manpower, resources, equipment, surgical people, and obstetrician. You are the person who will be coordinating with them. Suppose you are alone, it doesn't mean that every time suppose your consultant on call is far off and it will take time. The fetal discharge you have to take up immediately.
Yes, sir.
I'm talking about the section only. Section won't give you time. Okay, then I think prepare both the simultaneously. You can't say surgeon first, then the obstetrician. You have to prepare simultaneously. But similarly, if this patient come with the laparotomy emergency, with the burst appendix or something like that, or sometime like a strangulated hernia, but that patient will still give you some time. That will give you time at least half an hour to 1 hour. You can prepare that patient, optimize that patient. You can do the surgical preparation. Rest, I think you proceed the way you have already been giving that local, and as you go, the ketamine with the skin slightly releasing the burn contracture, infiltrating the local with at every step with slight ketamine augmentation, you can proceed with that. So basically, these are the patients, these are the cases which make you a very good clinician rather than they will make you a graduate from a student to a clinician. So these type of cases you should be knowing how to handle that too, and not alone as well in periphery also with the minimal gadgets available to you.
Yes, sir.
In periphery maximum you will have maximum LMA.
Yes,
Yeah.
sir.
A very simple LMA you may be having, not more than that. No combi tube, nothing, no fiber optic, no, the fast track, no any other iGel something. iGel may be, I think, available nowadays, but very difficult to have these provision of these equipment in the periphery.
It is
So
not
that's what
available. It is not available at the periphery also. The anesthesiologists themselves buys to have
that's
a
what I'm
safe
saying.
time. Yeah.
It's
That is
it's
for the safety.
जब जान पे बनती है तो सब खरीद लेते हैं चीजों के
Yeah.
ऊपर. Yeah. I
This
think
is
I
what is
started.
actually we are doing, sir. Release of the contracture and then proceeding, because all the names in the chat box also people were saying that you might have all those fancy items and the fancy names, but these are just for the sake of learning, because it is meant for the PGs. They should actually know the names, but practically when it comes, most of us, we are not having the advanced gadgets.
Mhm. I think she presented very well. She was confident, but I think few questions should be asked by the audience, people who are having this one. They must be listening. They should raise their hands. I will just going to. एक minute, just wait.
Yes, sir. There are
Ma'am,
questions.
there's a
Yeah. I'm
there's a
allowed the
question
party.
for which has asked,
Which one?
if you don't have much advanced gadgets, then how will you proceed for the case? There's a question in chat box.
That Dr.
So
Jaya
I would-
has already answered, I think. And Dr. Jaya has answered. If we won't have any advanced gadgets, then we could just go for the contracture release under ketamine. And Dr. Bajwa has also mentioned that thing.
Let Anna
Yes, ma'am.
tell her answer in her own words.
Yes, ma'am.
I think whatever, even with the advanced gadgets, the problem, the depth of problem will remain the same. In
Yeah.
these type of things, suppose the burn contracture, fiber optic, I think must be available only in maximum 7 to 10% of the entire institutions of the country. I'm
Great.
talking about the hospitals also, not more than that. I am just arbitrarily commenting upon. Ideally, you should be having this uh, training in the during your postgraduate level, how to handle these. That's why I asked this question to Anna. Patient landing up in emergency, that means in the periphery or in the remote areas where you don't have any help, how to proceed further. You have to garner all your skills, your knowledge, your attitude, how to handle these type of patients. That's how you really graduate from a student to a clinician, a good clinician, because you are going to be a lifesaver. You're going to be a manager. You're going to be, a multidisciplinary task leader. So I think even the simple laryngoscopy and intubation will also help if you have at least that, because in many peripheries I don't see a laryngoscope with that cells missing in that laryngoscope. The light is going off in these type of cases. Suddenly, then you can land up in a problem like that. So these are very important, and dealing alone with these type of emergencies take you much.
Very well said, sir. It's a very important issue to be addressed. That same kind of patient can be present for some other kind of surgery, non-emergent or emergent. Then how to proceed for the case? Where we find that patient could be done in regional anesthesia. And what about for emergency airway management? If your spinal get failed or your epidural is not complete per se for the anesthesia procedure. So very well addressed, Dr. Bajwa sir.
I think there should be people who should be asking, because these are the cases which should be.
They get in the exams.
Yeah, they will
Definitely,
definitely get.
Dr. Hana, from the plans that you had mentioned for management of this case, your plan A was awake fiber optic intubation.
Yes,
Plan B was awake video laryngoscopy. And then your plan C was using ketamine to release the contracture and then put in a supraglottic device. That is, if I remember correctly, that was the sequence that you had mentioned, correct?
Yes,
Now, coming to the question that Bajwa sir has asked, if this patient comes in an emergency, is it always that you will consider supraglottic device before releasing the contracture before inserting a supraglottic device? Can you put the supraglottic device in these patients even without release of contracture? Even maybe I would venture out to suggest that as a primary airway device? Would you consider it?
So there are two things to consider. One is the mouth opening of the patient, and we know that there's a fixed flex deformity. Now, if the mouth opening is adequate, more than 2 fingers, then we may attempt to put a laryngeal mask airway without releasing the contracture. But some of the problems is that because the axis is not, the oral and laryngeal axis are very acute, so the LMA may get butted onto the chest wall. And also the anatomy is distorted because of the neck contracture. So we're not sure if the LMA will place properly or not. So I would prefer to get the contracture released and then secure an LMA. And even if I had to intubate, then I would definitely get the contracture released before I proceeded for a laryngoscopy.
Yes. So, with these preformed LMAs, you really don't need to align the pharyngeal and the laryngeal axis for because it is not an intubation, correct? The three-axis alignment theory is mainly for the intubation process. So it is a possibility that even with a very fixed flexion deformities, you can put in, yes, obviously, as you mentioned, the mouth opening has to be there. Those factors have to be there, but you can still consider, and especially in an emergency, like you should not just remove it, like we'll release the contracture and then put the LMA. That is my personal opinion. Yeah.
Yeah. Even after
Well
releasing
said, sir.
the contracture, you're not sure whether you will achieve that proper oxygenation and ventilation with supraglottic devices. Especially because of that contracture and deformity at the inner side. So that is important. You
Yes,
have to see
that is correct, ma'am. And for these contractures, especially these fixed flexion deformities, many times those flexometallic LMAs can be useful.
Yeah. The neck
And-
mobility is also very restricted. There was no neck mobility. The mouth opening in this case is 2 fingers. If it is less, then it will be difficult to use the supraglottic airway device.
And for me, the most important is the person who is standing on the neck of the patient, the surgeon. If he is not experienced, I'm thinking you are going to land up in a mess again. Because these steps are very, very crucial, how to release the contracture and how to preferably go step by step. Because if you just put another senior resident assistant professor, he may not be well versed with the techniques that come with the years. Because these contractures are very, very difficult and tricky, sometime engulfing the larger vessels also, sometime engulfing the nerves also, and the tissues are in such a mess that you may injure the trachea also during release of such contracture. So I think first of all, I told Hana, when you gather the support for the surgical side, see that your surgeon is confident enough, because your entire further management depends upon his skills rather than your skills alone. So you have to make it sure that also.
Well explained and very informative session, ma'am. And I congratulate Anna for your great efforts at this stage of third year only. So congratulate Pratibha ma'am and Jaya ma'am too for your nice coordinations with explaining each and everything whatever audience has required, and you answered all the chats efficiently. I just want to add one more thing before closing this session, with the permission of Dr. Bajwa sir. Sir, it's my personal experience. In one of case, ventilation with mask was so difficult, or the placement was so difficult, just because of contracture of the neck downwards up to the neck. So we put Randall Becker mask in the oral cavity to make a good seal. So I just wanted to add this at this platform. Sir, with your kind permission and your kind visionary words, can we end up or sum up the session?
No, because before ending, there may be sometime people who are a little shy. They can still have opportunity to ask.
Somebody has just put a question: what is the role of nerve blocks? Nerve blocks can definitely be given if the anatomy allows you to do. With this all contractures and the fixed flexion deformity, you are not able to localize the anatomical landmarks. So nerve blocks are going to be very difficult. You simply
Even
cannot do it.
ultrasound guided nerve blocks are very
Yeah.
difficult because the tortuous nature of
Not
the
me.
fracture in the nerves and gult. It's a very difficult part on the nerve blocks.
One is the anatomy
I
is on.
think local anesthesia is more important. That's why I said the surgical techniques. The good surgeon will help you relieve that airway for you. Nobody else.
Correct, sir. Correct.
So the audience can unmute themselves if there are
Yeah,
anyone who
they
can
can.
interest to
Hmm.
speak, or there are some comments. They are welcome to speak out.
Because majority of the audience have already passed the PG examination. That's why they are not asking. They are must be undergoing the practical parts. They must be dealing with every day.
Yeah,
How
can I
many
ask
sir?
one question?
Yeah.
Yeah, Dr. Sunaina,
Sure,
please,
ma'am.
please.
Yeah, hello, sir.
Bas
So,
बढ़िया,
what is I would like to ask, what is the role of hybrid techniques in these cases? Like in this patient, the mouth opening is 2 finger. That means around about 2 centimeters. So, suppose if the fiber optic intubation fails awake, so awake other hybrid techniques, can these be used?
You want me to tell the hybrid techniques, or you are telling me some techniques?
Yeah. Can we use hybrid techniques in
Yeah, it is. See, the main aim is to establish a airway safely. So, awake fiber optic is one option. You can go for orotracheal, nasotracheal if the patient allows you. Otherwise, we are discussing that supraglottic airways can be used. And if you are in a very good institute, all those fancy names which Ahana said, the glide scope, the McGrath Mac, and whatnot, these are available. Video laryngoscopes, they are coming up.
Yes, because
be-
yes, ma'am. Because video laryngoscope plus fiber optic, if both used,
I
it is
read
quite
somewhere that
beneficial.
that is termed the WAFI technique, video laryngoscope assisted fiber optic intubation.
Yes, it's
Another
very good.
fancy name, yeah. It's
Yeah, but if you have a fiber optic, that means in that institute we have video laryngoscope also, and
also, yes.
especially, so if we have a channel video laryngoscope, so we
Yeah.
can always put the fiber optic
Definitely.
through that channel. So
Those
it is
will
very
be-
easy. It becomes easy.
Yeah, but the video laryngoscopes, the blades are angulated to a very large angle. So sometimes
Yeah.
it is necessary to use a stillet, because without that you won't be able to do. And those channel ones you said, then through that channel you can pass the endotracheal tube, and that will not be needing the stillet.
Yeah, I'll just share my experience.
Please.
I have used a channeled King Vision video laryngoscope. So in a mouth opening of just 17 millimeter. So I was able to use and along with fiber optic, we could awake intubation we were able to do.
Yeah,
So,
less than 2 centimeters, they advocate the use of this channel.
It is like I have used it personally, so that's what I'm telling. It was the
That's
mouth opening
great.
of the 17 millimeter, so we
I have
can use.
I have seen all the pictures in the recent textbooks. We don't have them
No,
with
no,
us.
I have used it. That's what I want to share my experience.
Great.
Yeah, ma'am,
That's great.
that's actually how the science evolves. Use the technique. Sometime we with the innovation, sometime with the availability of the equipment. Certain things may not be written in the textbooks or even the journals, articles.
Yes.
When you come across your own personal practice with your own wisdom, you do the things, and they really become a good practice later on. And if you keep on doing that thing, you become expert in that. Somebody asked how to fix the ETT or LMA when burn involved face. It's very simple. Just do the suturing. Just take a suture, put a thread around the tube or the LMA. That is, I think it will be very well secured there. Sometimes with the adhesive tape may not be able to fix properly, so you can use the suturing. And regarding the different technique that just Dr. Minugol said about that using the rental RBS mask and later on now on the king size. So there are other equipment also, techniques also, positionings also, many things I think, and we can have a better knowledge and understanding of this situation when we attend the surgical plastic surgery conferences also, because they deal about the surgical techniques of how to release the burn contracture. When you see those techniques, then you can always think of how to evolve your anesthetic techniques according to their advancements also. So So I think it's a very, very good coordination between different specialties when you go ahead with that. Just putting up our only airway management things is not going to help us. I think the science will go forward only when there is a good coordination and cohesion between the different specialties. You understand the things. The way I told that obstetrician, she must be having a look at the uterus and fetal distress. She will not see what the burn contracture and anesthesiologist is going to face. And similarly, a surgeon will not understand a fetal distress or how it is going to, whether that can wait or not. The anesthesiologist who will be coordinating and, doing all the leadership work here. So these are the scenarios where I think it gives a birth to advancements in the specialties and techniques. Raghunandan, you want to say? You just
Yes.
unmute yourself. Dr. Raghunandan is there.
So
Where
many
he
a
is?
times we use a long ribbon gauze, tie a knot at the angle of the mouth, and then around the neck you can use it to fix the tube. Besides
Yeah.
suturing, as you rightly said.
Exactly, that's what I'm saying. So these are the techniques. Very well, you can think of every time you try to make yourself safe, a better place for a safety for yourself and the patient, and things start getting evolved. Raghunandan was raising hand. Where is he gone? Yeah, Dr. Renu Vatkar, madam, Shobha Vatkar, madam. She has said teamwork. I know, so teamwork is always important.
So, Sir
Lalit
Dr.
sir is there.
Lalit Kumar Raega, sir. So you can
Lalit sir,
unmute
unmute
yourself.
karo, unmute. Sir, unmute kar
Good
lijiye,
evening,
unmute.
sir.
Yeah.
Good evening, sir.
Yes,
Good
sir.
evening,
So
sir.
nice discussion.
Thank you, sir.
One more to add is the Bonfil gadget
Bonfil, yes.
or the unlighted slits. I have used it, and with the less mouth opening, it's worked.
Mhm.
Yes.
Yeah, it works very well.
Both are different things. Lighted distillate and Bonfil, both are two different things.
Yeah, both different, but same mechanism there.
Sir.
With this lighted slit also, they won't be that much useful, what I feel, with that large band of contracture in the front of neck. It will be difficult to appreciate the glow. Bajwa sir, what is your opinion?
Unlighted slit is flexible.
No,
The
no.
thing
We
is
can able to
that
make some curve.
now the only problem is here. You see, all the contractures are not same. The degree
Yeah.
of distortion is not same. The
Yes, sir.
mouth opening, the angle of mouth opening, the glottic opening, the pharyngeal spaces, everything is different. Certain equipment may be well best, can be working very well in certain patients. So it's the assessment by the senior most anesthesiologist who have experience in these type of cases, whether the Bonfil or the lighted Stilet or your fiber optic or the simple laryngoscope or the video laryngoscope, which is going to help. Here comes the role of the experience in life, your years. Now, Lalit Raigar sir is so much of a having experience. Madam Shah and Madam Lalwani, they are having so much experience. They see the patient, then they decide that which is the best equipment to handle in which situation. In fact, that's what I was saying,
Sir,
Ahana.
yeah.
Graduate.
Sometimes check laryngoscopy with local anesthetic spray
Hmm.
with McCoy blade. I have done one case.
Yeah. So that's why
Yes, sir.
each and every individual case throws a different challenge and it teaches you a different thing. With I think if somebody must have done 100 burn contracture neck cases, his experience will be vast and immense and
Yes, sir.
the best person to tell how to go about it in all the difficult cases of such types.
Yes, sir. Thank you, sir. Thank you, Lalit sir.
If the contracture is second or third degree, then even the McCoy blade we cannot achieve. We cannot.
Yeah,
It's very
definitely.
difficult to lift the epiglottis with that, even with McCoy.
That is not working that one.
Yeah.
Yeah.
Yes.
So I think that there was one last message that was the best. If such certain cases come like that, if possible,
Check.
that the patient can be transferred, always transferred to the higher centers where the all the resources and manpower is available, rather than playing with the life of the patient in such a taking on the your own ego that or your self glory to intubate such patient or to give anesthesia to such patients. So
Saying
that's better
no
to
as earliest.
especially
Dr.
refer.
Baj,
Yeah.
Dr. Bajwa,
Ruchi
can
ma'am,
I
Ruchi
add
ma'am.
one thing?
Good evening,
Yeah,
ma'am.
ma'am, please. आप बड़े दिनों के बाद मिले हो यहाँ पे. Yeah, ma'am,
You
please.
know, these contracture necks, no, the two things are very important that even if you release from front of the neck, still there is so much of tension in the tissues, it is,
Yeah.
does not release it totally. So
Yes.
in these specific cases, I think nasotracheal intubation helps. That is what vast experience we have done because of being a wife of a plastic surgeon and a burns surgeon. So that's how I've dealt with it. And second is like when in within the 3 months, any front of the neck burn should be treated as contracture neck, because the contracture neck which we are normally dealing with, sometimes they are softer, they soften with time. After 6 months they soften with time. They don't pose that much of difficulty than the fresh uh, contractures within the 3 months of healing phase. They're very tight, the tissues are very edematous and tight, and if you try to release them, they bleed a lot. They just bleed like anything. So I think in these are the situations where LMA and all these things help. But in case if these gadgets are not available, then nasotracheal intubations are very, very helpful in such situations.
Yeah.
Thank you so much,
Definitely,
ma'am.
Yeah.
Postgraduate diploma exam.
So this
Ma'am has
just
provided a first-hand information about cases. So informative.
I think everybody has expressed their good messages
Yes,
and
sir.
experiences. These are very important even for the examination. Anna, you should be learning, and your colleagues should be learning because of these. This is the best platform where you can interact with the seniors. You can get prepared for your examination. All the questions being fired at you by the externals or the internals, you will be able to answer now. I think you must have graduated. So before closing, I
Ji,
think
sir.
we should be
Lalit sir
felicitating our
wants to add
students.
something. Lalit sir wants to add something. Sir, please unmute
मैम
yourself.
आप भी ऐड करना पहले मैम डॉक्टर प्रतिभा जैन शाह को थोड़ा सा हमें फेलिसिटेट करने
Ji,
दीजिए.
sir. I was reminding of that only.
Now, Lalit sir
Yeah.
had raised his hand, so I thought
Yes,
he wants
ma'am.
to add something.
Sir,
हाँ
we can
करते हैं
take.
मैम करते हैं अभी इसके बाद करते हैं.
Yes,
मैम
sir.
प्रतिभा थैंक यू फॉर being the leader of this team to have such a wonderful class and discussion. This is a small gesture from ISA National to felicitate you, ma'am.
Thank you so much, sir. Thank you so much.
Thank you, ma'am.
Thank you. Thank you.
And equally, thanks to Dr. Jaya madam also. She has
Thank
done
you, sir.
put a lot of hard work in preparing their PG students, the Dr. Anna. So
Thank you,
thank you
sir.
very much, ma'am.
Thanks
Thank
to
you,
you.
Dr. Jaya, ma'am. It's a very nice presentation by your student. And
Thank you.
interaction
And
was
Anna,
quite informative, I must say.
and Anna, you were very good, very confident as well as very much patience also. Having a good patience you showed today. That's how the final year PG student should be showing in the examination. Good. Now I think you will be able to graduate to the next level after this class also.
Definitely.
Yes, sir.
And Dr. Meenu, it's your debut performance as a senior coordinator, so you have done a very well.
Thank you, sir. Thank you.
And we keep doing. And Asha, on a very short notice, you have come as a coordinator. It's good. You will be getting opportunities again in the coming days. So thank you very much, Asha, for coordinating this event.
Thank you for giving me this opportunity.
And great thanks to Dr. Madhuri Kurdi and Dr. Nishant Sai for being the excellent coordinators for this class setup and the preparation for all the people, for all the coordinators and the students. Now, I think before closing up, I think Dr. Lalit wanted to say something.
So
So
just to youngster, one message.
Yes, sir.
As in resuscitative
Yes, sir.
phase, whenever we get a call for intubation,
Yes, sir.
always try to put a smaller tube. My experience is first attempt is last attempt. If there is airway
Definitely.
burn is there, 6 number tube has to be preferred, and that will be or railroaded with guide wire. Because once we get some injury, there may be edema and it is difficult to maintain the airway. 6 number tube has to be prepared with guide wire.
I think that's a good suggestion.
It's a
And we
wisdom
are-
of Paul, sir, for the students. Thank you,
Yeah.
sir.
Thank you, sir.
Yeah. Thank you, sir. Thank you, everyone.
Thank you, everyone, for
Thank you,
making
Dr.
this
Nishant, Dr.
academic
Meenu,
session a
Dr.
great interaction. Thank you, ma'am.
Before
Thank you.
closing the classes, we always say, long live ISA.
Long
Long
live.
live ISA.
Definitely, sir. Long live ISA.